Hey, welcome to the Lichen Sclerosus podcast. My name is Kathy, and this is our journal of learning about and living with lichen sclerosus. Today, I'm so excited to introduce the new frontier for the Lichen Sclerosus Support Network. I have a very special guest and a very special surprise for you. So without further ado, let's get into it. Welcome, Dr. Foster. I'm so excited to be here with you. I am going to let you introduce yourself and then we'll get into our surprise.
My name is Dr. Erin Foster. I'm an associate professor of dermatology and obstetrics and gynecology at Oregon Health and Science University in Portland, Oregon. I'm a mucosal specialist. I see patients who have diseases of the mouth, esophagus, the vulva, the genitals, and the vagina. I'm excited to be here.
Yes.
Also on the medical advisory board of the LSSN.
Love it. So, Dr. Foster has been with us for years, and we have been focused on lichen sclerosus, but we're so excited to announce that we are moving into our lichen planus era. So you are on our email list. You have recently gotten a lichen planus survey, and you're probably like, what is this? Now you hear it. We are moving into lichen planus, and Dr. Foster is going to be the head of our LP department. And we're so excited to have her on and learn from her. We decided to do this because lichenoid conditions have some similarities, but they also have some drastic differences. And a portion of our lichen sclerosus community also has some form of lichen planus, and they don't have a home. We're going to be that home. And we're so excited to partner with Dr. Foster and her team to start educating our lichen planus community and growing it. So excited.
Me too. Yay. This is a really important resource that is, patients are going to just be they're going to be so happy that this is happening.
Thank you. So for our LS community that is listening, can you walk us through what is lichen planus and then what makes it different from LS?
Thanks for asking. So lichen planus is an autoimmune disease of the skin. So that's similar to lichen sclerosus. It even has similar immune cells that are involved, T cells. But the difference with lichen planus is that it can affect many more sites. So people can have lichen planus of any mucosal site in their body or their skin. So mucosa would be like their mouths, inside their esophagus. It can affect their voice box, up their nose and their ears and their eyes, and then can affect their vagina as well as their vulva, or can affect the penis. It is a very painful disease when it's inflamed, but it also can cause really severe scarring in these areas. So patients who have oral lichen planus often have trouble opening their mouth really widely. If they have it in their esophagus, they might have trouble swallowing, they might choke. Or if they have it in their vagina, they might have actually scarring so that a speculum couldn't fit in or so that somebody can't have penetrative sex. That is a little bit of overlap with lichen sclerosus because that can happen, but that's primarily on the skin surface, not on the mucosal surface.
Wow. And then with LP, you can also have it like in your scalp, right?
Yeah. So on your skin and on your scalp, those are, so LPP of the scalp is lichen planopilaris. Pilaris means hair. LP of the skin, there's lots of different kinds. Lichen planus of the scalp can be really, really traumatizing because it is a scarring hair loss. And so when people have inflammation of their scalp, it's usually in the front or right on the center of their head, and they'll have a burning feeling. They'll have sometimes a scaly rash, and then they lose their hair, but then the hair follicles scar down, so they can't make new hair. And so a lot of people, once they've lost their hair for lichen planopilaris, it doesn't grow back.
Wow. Okay.
Really important to recognize and treat it early.
Yeah.
Because you can reverse the inflammation, but you can't reverse the scarring from this disease.
And so if someone has LS and they're wondering, do I also have LP or can I also have LP? Specifically on the vulva and the vagina area, how does it look different from LS?
So this is a question that is actually very much not known. So even you can even have a biopsy of tissue from the vulva that comes back as lichen sclerosus, but a clinician would say, gosh, I really thought that was lichen planus. So right now, the difference that most of us are using who are vulvar specialists is that if it involves the vagina, then that's lichen planus. If it's on the surface of the skin, the dry skin, the keratinized skin, or just at the base of the vagina, at the perineum, that's more likely to be lichen sclerosus. I would say, even as someone who's actively researching this, I used to think I could tell but just by looking. And I've had now numerous patients where they've come to me, I diagnosed them with lichen sclerosus, treated them, their skin got better, but then something happened so that their vagina became inflamed. And then I thought, oh my gosh, do you also have lichen planus, or did you have lichen planus all along? I think the other thing that is more common is to have mouth sores, and the location of the mouth sores really matters. So if they're on the sides of the tongue, inside the cheeks, or if the gums are really inflamed, bleeding, tender, or if the tip of the tongue feels like it's burning on hot coffee more often than it should, then those are all symptoms of lichen planus.
I've always thought, and this is something that I heard a while ago and obviously may not be true anymore, but if it was white, if you had like white skin, it was LS. If it was red, then it was LP. And so the lines are blurred now?
Yeah, that's how I was taught. And I only graduated residency 5 years ago, 2020, 5.5. And now what we're realizing is that hyperkeratotic LP, lichen planus, can be white. And so if you have it around the vulva, it can be white and look just like LS.
Wow.
Most of the time, we think of it as erosive, so it's red. There's the top layer of the skin is peeled off, and there's like a white lacy border to it. That's more classically what vulvovaginal lichen planus looks like. But I have lots of photos of patients either that have been published online or my own patients where they had what everyone thought was lichen sclerosus, even showed it on the biopsy, and then didn't respond to lichen sclerosus treatments or biopsied later, and it was found to be lichen planus.
Wow.
Yeah.
So talking about treatments, great segue.
Mm-hmm.
How does LP treatment differ from LS treatment?
Yeah. So LS and LP, mainstay first line is topical corticosteroids, usually something in the clobetasol range, unless somebody has pain or burning, in which case usually we'll go to like mometasone or triamcinolone. So those are topical steroids used regularly. And I would say for most patients with LS and maybe half of patients with lichen planus, that is sufficient and great treatment. I do have some lichen sclerosus patients that need to have more aggressive treatments. They have to go on a systemic medicine, pills or shots or something. It's more rare in lichen sclerosus. In lichen planus, I think more people need to be on systemic medications. The exception is if we can find a medicine that triggered this. So we haven't talked about this yet, but there are some lichen planus looking reactions of the skin that are triggered by medicines. And so the most recent one that we found out is immune checkpoint inhibitors that are used to treat cancers. So there's melanoma, a patient has melanoma, they get it removed surgically, they go on sort of this chemotherapy that harnesses their immune system and activates it to fight remaining cancer. The problem with an overactive immune system is that the flip side is autoimmune disease. So patients will have terrible erosive lichen planus of their mouth, terrible erosive lichen planus of their vulva, their vagina, their penis, whatever. And so there are other medications that are more common that people take all the time that can also cause this type of a reaction. And so the very first thing that I do when I see a new patient with lichen planus is I check their medicine list. And the timing of the medicine is crazy. So it's not like you take your dose of your medicine and the next day or a week later, people have the reaction. It's 3 to 6 to 9 months after their first dose. And so It can be, for example, somebody had a knee surgery, so they took a ton of ibuprofen, and then 6 months later, they erupted into lichen planus because ibuprofen is one of the trigger medicines.
Are you kidding me?
I'm not.
Oh my
I don't
God.
want to scare people.
I know.
I don't want
'cause,
people
like,
to stop
I
taking
take
it.
ibuprofen all the time.
Don't we all?
Wow.
And so for patients, when they come in and they have either like a prescription level ibuprofen or they're taking a lot of Aleve, I have to say that, like, this could be making it worse. I don't know.
Right.
I've had a few patients where they've just stopped cold turkey and their lichen planus has gone away. More commonly, the medicine sets off kind of this immune reaction, and stopping the medicine isn't the cure. It can help it, but it's not the cure. But these are medicines that are really commonly prescribed. So diabetes medicines like metformin, blood pressure medicines, metoprolol, beta blockers, all sort of ibuprofen, Advil, it's crazy.
And so, with that being said, is there enough research that, like, on the labels of these drugs, is like lichen planus listed as a possible side effect?
No, definitely not.
Oh,
And I think, even in the dermatology teaching, the study books say you can't get mucosal lichen planus from these medicines. But I would say me and my colleagues, we all know differently. We've seen this happen. You initially asked me about the treatment options between
yes.
LS and LP, and I took a very long
Yeah.
circuitous roundabout, sorry. Topicals are first line, but second line, there's a medicine called hydroxychloroquine that treats lupus and other autoimmune diseases. That's my next line.
Is this a systemic?
It's a pill.
Okay. Pill.
Yep. Really great medicine. Safe to take during pregnancy, but that takes about 3 months to start working.
Oh, wow.
And so that's the first line after topicals, sorry. And then after that medicine, methotrexate, which is the weekly kind of T-cell immune modulator. And then after that are the new medications, JAK inhibitors. I prescribe a lot of those. I haven't found those to be as effective as methotrexate, but they do have fewer side effects. All of these have terrifying lists of possible side effects, but most of my patients, as long as we get the dosing right and as long as they really need the medicine, most people do really well.
And so, with the dosing, is this something like it's a little bit experimental?
There's no FDA-approved medications for lichen planus.
Which I found interesting when I went to AAD that there's for LS either.
No.
I was like blown away.
Right. You're like, how is
this?
No, because nobody has pursued that.
Yeah.
So, which is crazy.
It is.
So it's all off-label.
Yeah.
But, what we do is we read the literature and we study our patients and we, talk to each other. And so there was just that lovely study that Shola Vaughn's group at Medical College of Wisconsin did about acitretin versus methotrexate for lichen sclerosus. If you need a systemic, which one's better? So I prescribe methotrexate. Turns out that one's better. Hooray. Same thing is happening now for lichen planus. There's a case series where people are trying this and they're trying this and they're trying this, and we're all just trying to figure out. I would say there are a few medicines I don't prescribe as often just because they have worse side effects or they have worse long-term outcomes or because I'm not comfortable with them.
Yeah.
But it's all, each medicine takes about 3 to 6 months to kick in.
Wow.
And so we're just, a lot of the process is being present with the patient while they're going through this really hard time.
Yeah.
Yeah.
And I think that's also why we decided to partner and create the space for lichen planus patients, because right now there is no home for them. Just like we created a home for lichen sclerosus patients, if we create that home for lichen planus patients, and then we bring those voices together and say, listen, we need research, we need treatments, we need a clear diagnosis, strategy. We need doctors to be properly trained in this, because there is this huge group of people that are being underserved. We can do that, right?
Yeah. I mean, it's considered a rare disease, and I really don't consider it that. Same with lichen sclerosus. I think it seems like it's been pretty clear that it's been more numbers since COVID, and people have flares with stress, but also with vaccination sometimes.
Just like LS.
And so it feels like this is untapped. And I mean, that's again why I'm so excited, because I have a lot of LP patients who are LSSN followers, because that's, you guys talk about a lot more than just the disease. You talk about how to live and sex and topicals and pain and sex therapy and pelvic floor PT. So yeah, it makes sense.
Yes. I'm so excited to go into this new frontier with you, and really I'm excited to sit here and have another conversation with you in 4 or 5 years and see how we have changed the landscape. I had a conversation with Dr. Kraft in December, and it was like a 4-year check-in, and she's like, the difference is like night and day from what her patients were coming in 4 years ago to where they're coming in today.
Yeah.
And I'm excited to have that conversation with you in 4 years with Lichen Planus patients.
Oh,
and
I just got goosebumps.
Me too. Me too. Because
Yeah.
we're going to change the landscape. We're going to get more eyes on this. We're going to give people a home.
We have to.
Where they can congregate, and because community is so important.
Yeah.
So important.
Yeah. And that gives people the tools to then go back to their clinicians and doctors and say, hey, you should know this. You should read this. You should be listening to these experts.
Not only that, on the mental side, when you have hope, your body responds.
Yep.
And it's easier to heal.
Yes.
Loss of hope, it's like you just deteriorate.
Yeah.
So
no,
we're all about hope here. We're so excited. If you are listening and you have Lichen Planus, just know we are here with you. Join our email list at lssupportnetwork.org/subscribe, because we're going to have so many resources coming for you. In September, we have a LP Summit. It's going to be a 3-day, Friday through Sunday summit, where we are going to deep dive with the experts into LP. So just know that we are going hard for you, just like we went hard for LS, and we're going to continue to go hard for our LS community as well. So don't think we forgot about you. We're just adding some new brothers and sisters into the mix. And yeah, I'm so excited.
Yeah, me too. It's long overdue. I'm glad this is happening.
So thank you so much. I cannot wait. I know we're going to have some more interviews to deep dive into specifics. If you have LP or you have questions about LP, definitely send it to support@lssupportnetwork.org. Let us know, what do you want to learn about? What questions do you have? What resources do you need? And so that we can create them, because we need to know what's going on with you guys. So thank you, Dr. Foster.
Thank you.
This was an amazing conversation, and I'm so excited.
Me too. Thank you.